All right, let's dive right in. Today we're talking about one of the most challenging situations we face in anesthesia, dealing with a patient who has a compromised cervical spine. And let me tell you, this is so much more than just a sore neck. It's a high-stakes scenario where every single move we make matters. So let's get into it. So get this, 2/3. That's how many of us will have neck pain at some point in our lives. It is incredibly common. And that means, as an anesthetist, you are going to see patients with cervical spine issues all the time. It's unavoidable. Which brings us to the big question, right? If it's so common, why is it one of our biggest nightmares in the OR? Well, because if you don't know exactly what you're dealing with, the simple act of securing an airway or even just positioning the patient can cause a spinal cord injury. And that's a catastrophic outcome we absolutely have to prevent. So here's how we're going to tackle this. We'll start by really understanding the problem. Then we'll walk through preoperative planning, what to do in the OR, what to watch out for afterwards, and we'll wrap it all up with a super high-yield checklist that's perfect for your final exams. Okay, first things first, let's define the core challenge. What exactly are we up against when we talk about cervical spine disease? So this slide breaks down the two main reasons these patients are coming to surgery in the first place. You've got myopathy, that's when the spinal cord itself is getting squished. Then you have radiculopathy, which is pressure on a nerve root as it's trying to leave the spine. Knowing the difference is really key to understanding your patient's symptoms and what the surgeon is trying to fix. And underlying all of this is the concept that should keep us up at night: spinal instability. This is our number one concern. It basically means the spine has lost its ability to protect the spinal cord during normal movements. So our job, from the moment we meet the patient to the moment they're in recovery, is to be the spine's protector. And how do we know if it's unstable? Well, it's not just a guess. These are the hard numbers from the radiology report that you have to look for. Seriously, treat this like a flashcard for your exam. If you see more than 3.5 millimeters of translation, over 11 degrees of angulation, or an ADI bigger than 5 millimeters, those are massive red flags. Right, so now that we know what we're looking for, let's talk about the preoperative plan. This is where the magic happens. A solid plan is, without a doubt, the foundation for a safe anesthetic. You know it, I know it. Airway is king. But here's a really important clinical pearl from the source material. We tend to fixate on neck extension, right? But in these patients, a small mouth opening and a poor jaw thrust are actually much better clues that you're going to have a tough time with laryngoscopy. Okay, beyond the airway, here's your quick systems check. Respiratory. If their vital capacity is less than 15 mils per kilo, they've got poor reserves and might need a ventilator after surgery. Cardiovascular. Make sure that blood pressure is under control before they get to the OR. Neurological. Document every single pre-existing deficit. You have to know your baseline. And finally, hematology, stop those NSAIDs 2 days before and make sure you have blood ready to go. All right, we've done our homework, we've got a plan, now we're in the operating room. Let's talk about how to actually do this safely. So, for induction, we're using our standard toolkit, but with a couple of smart additions. Notice that small dose of ketamine. It can really help with pain control after the surgery. And for maintenance, this is key. If the surgeons are monitoring the spinal cord, you're going to want to use total intravenous anesthesia, or TIVA. Why? Because the gas anesthetics can mess with the monitoring signals. So how do we secure the airway? Well, you've got a few choices, but the most important thing is to do what you're good at. Now, if you know you're dealing with a difficult airway and an unstable spine, awake Fibreoptic intubation is pretty much the gold standard. For other cases, though, a careful direct laryngoscopy with someone holding the head still, what we call manual inline stabilization, or MILs, is a totally reasonable technique. Okay, the tube is in, patient is asleep. Our focus now pivots completely to protecting that spinal cord. And this formula is everything. Spinal cord perfusion pressure. It's your mean arterial pressure minus your cerebrospinal fluid pressure. Every hemodynamic decision you make from here on out is about making this equation work in your patient's favor. And here's how we actually do it. To keep the MAP side of the equation high, we need to be obsessed with their blood pressure. That means big IVs, an arterial line, and treating any drop in pressure instantly. To keep the CSF pressure side of the equation low, the surgeon might even put in a lumbar drain. See? It all comes back to that one formula. The surgery's over, but we are not out of the woods yet. The postoperative phase has its own set of dangers we need to be ready for. Now, this is so important. The airway you dealt with at the beginning of the case is not the same airway you have at the end. Swelling or a developing hematoma can turn a simple airway into a life-threatening emergency. And the scariest part, it can be totally hidden underneath a neck collar. So, what's the one thing you must do before you even think about pulling that tube? A cuff leak test. No leak means there's swelling and that tube is staying right where it is.
Okay, we've walked through the whole process. Let's boil this all down to the 3 absolute must-remember points for your exams, and more importantly, for your practice.
Takeaway number 1, your prep work is everything, period. Identifying all the risks with the airway, the neuro exam, the stability of the spine before you start is the most important thing you can possibly do.
Takeaway number 2, once you're in the OR, it is all about perfusion. You have to protect that spinal cord. Know that SCPP formula, live by it, and actively manage it. Your patient's neurologic outcome is literally in your hands.
And finally, takeaway number 3, be paranoid about the airway. Always. Expect it to be difficult beforehand and expect that it might have become difficult by the end. That constant vigilance is what keeps patients safe.
And just so you know, all the principles we've discussed today are drawn from the fantastic 2011 continuing education article, Cervical Spine Disease and Anesthesia by Drs. Taylor and Kumar.
So I'll leave you with this to think about. With this framework in mind, from assessment to planning to execution to recovery, how are you going to feel the next time you see unstable C-spine on the patient list? Hopefully a lot more confident. Thanks for tuning in.